Up next, Waldo is joined by Dr. Daniel Lenihan, professor of medicine at the Vanderbilt University School of Medicine. They discuss cardio-oncology intensive.
Welcome, Dan.
Thank you so much.
So this is a relatively new subspecialty in cardiology. So you want to just tell us a little about cardiac oncology, to be cardio-oncology to begin with, and then we'll get right into the biomarkers.
Sure. Well, I think it's kind of grown out of necessity because, patients that we get consulted on that have developed significant cardiac issues while they're undergoing treatment for cancer. And then the other major component are people that were treated years ago for their cancer with different treatments and ended up with, complex cardiac issues years later. And so for those reasons, there's just a rising number of patients that could benefit from cardiology input.
So let's then talk about the biomarkers. Tell me which one we should talk about first.
Well, I think that I could probably just lump the two natriuretic peptide measurements as one, the N-terminal proBNP and the BNP. Obviously, they're different in ways, but as a whole, they're pretty useful in the context of cardio-oncology. And then, of course, high-sensitivity troponin is becoming an important adjunct measure as well.
And so when you're doing screening in cancer patients, do you get all three?
No, pretty much I would say in terms of the natriuretic peptides, one or the other. And then in terms of troponin, it does matter. Each institution makes their choice about what troponin assay they're using. But as time has gone, our sensitivity of the troponin is, it's much greater than it used to be. So primarily the institutions are going with, higher sensitivity of troponins. And so this is an important place where we have to understand what the low values mean.
So as it evolves, what would you recommend?
Well, I think that in my own practice, use BNP and troponin quite frequently, and in a variety of contexts, I think it is very useful in terms of understanding whether a person's at higher risk for the development of a cardiac issue, or if, in the case of, say, amyloidosis, where you can see the efficacy of the treatment through a drop in the biomarkers over time.
So let's talk about some of the chemo well recognized for doing this. Talk about how you use the biomarkers.
Historically, I think everybody is aware about anthracyclines in general, and of course there are a number of different anthracycline preparations that are used. So it's not any kind of mystery that they may be associated with cardiotoxicity. The problem is that we've never really fully understood that. We never understood how often it occurred and in which different cancer situations the dose of anthracycline may be different and the frequency of use. So there's just the idea that anthracyclines could be associated with toxicity is a very broad statement, and we don't really understand the specifics of it. And, for any individual patient, it's very hard to tell them that, you've got a 2% or 5% or 10% chance of having toxicity with this drug, even though we think you need it for your cancer. It's very difficult to sort of advise patients about that.
So how do you use the biomarkers then clinically?
The biomarkers help us understand whether any individual patient is at higher risk or has developed toxicity. So if you start out with a baseline normal BNP and troponin, for instance, and you're going through the course of your chemotherapy, if one of those changes, then that could be a sign, an early sign that the heart is having some issues.
And you intervene?
In that situation, just like if you were consulted on a patient that had some chest pain and you had a mild elevation of troponin, you may intervene in a variety of ways. That could be, just medical therapy, or in that case, you would consider whether to do any further testing. And so in the context of cardio-oncology, you look and see if there are any modifiable risk factors that you would treat better. So for instance, if they were hypertensive or hyperlipidemia. And then also there are some recent studies that suggest we can actually prevent the development of toxicity by using some of our typical heart failure medications.
Can you do this prophylactically, anticipating that you're going to need to use an anthracycline?
In some cases, and I think that's particularly a spot where the biomarkers are useful, because if you see that a biomarker is abnormal, then that would perhaps tip the scale in that individual patient that you should use preventative therapy, such as ACE, ARB, or carvedilol, for instance.
Okay. And what are some of the other chemo drugs that do this?
Of course, there are a number of different anthracyclines, and they're used in breast cancer and lymphoma and leukemia. And they're still considered, very important therapy. So it's not going to go away anytime soon. Trastuzumab or Herceptin is probably the next most famous one. Initially, there was a higher than expected rate of cardiac dysfunction with trastuzumab, but over the years, they've really refined how they deliver the drug and monitoring appropriately. And with that, the rate of cardiotoxicity is relatively low. It's probably in the 2 to 3% range. Then there's a number of new drugs. Of course, the anti-angiogenic or anti-VEGF therapies are known to cause significant hypertension. And then there's a class of drugs called the proteasome inhibitors, which are used for myeloma, that probably are going to have some cardiac toxicity issues.
Do you think that maybe cardiology should be consulted at the outset in patients who undergo chemo with these drugs? Is that happening?
We try to make it happen at Vanderbilt. I think that's yes. My answer to that would be yes, but it's really challenging to, in one context, just getting a cardiologist to engage in that concept, that they're doing something to prevent the development of heart failure or some other toxicity. And I'm not sure that we've collectively have thought about it that way. I would sort of vote that we do. To assess a patient's or a pre-chemotherapy setting, you want to think about what kind of risky procedures or treatments they're going to get and how can you minimize them or prevent them altogether. And I think that that's a very important opportunity for cardiology, I think.
And does the age of the patient make a difference in any of this?
Definitely. I think as you age, unfortunately, you're at higher risk for cancer, but you're also at higher risk for development of typical cardiology issues. And so, as a person gets into their 60s, 70s, or 80s and they develop a cancer and they're going to get some treatment, the chances that they would have previously undiagnosed heart disease continues to rise. So it's a very significant issue.
This is a very important area. It's relatively new, I think, and growing. Would you want to summarize a little bit what you think the major takeaway points are about the big picture here?
The biggest takeaway point that I hope people would understand is, especially cardiology really has an opportunity to make a very significant impact on the patients with cancer that are undergoing these treatments. And I think that if cardiology in general would apply their best practice knowledge to that setting, it does make a big difference. I know that we had talked previously about a patient of yours where, I think that it's quite possible that could have been prevented. And then you dealt with that issue in the way that you know well. But I think that could we do better to prevent the development of these problems? Using biomarkers is an important component of that.
Well said. Thank you very much.
Thank you.